Hi, everyone. Today, we are going to focus on medical and legal myths, that capitalized word over there, I don't pronounce it very well, and misconceptions about end-of-life decision-making. We're going to proceed this way. Our first speaker will be Dr. Michael Paletta, whom I will introduce in a moment, and he will cover medical issues. I will then cover legal issues, and as always, we'll have questions and answers at the end of the session, but if you are driven to ask a question during the session, feel free to do so. Dr. Paletta is an extraordinary individual, and it's my honor to introduce him.
Thanks, Andy, for that very kind intro. I'm going to challenge you a little bit this afternoon, challenge what you think you know about end-of-life care from the medical perspective, and I think Mr. Broder is going to also challenge you on the legal side. And I'll go through the information somewhat quickly, but at any point if I say something that doesn't sound right to you or you really can't hold your question until the end, you can interrupt me, but we will try to finish and have some room at the end for Q&A, because undoubtedly we generate Q&A. I'll start by asking a question, asking it of each of you. It's a rhetorical question, of course. Where do we get the bulk of our health information? So the things that we think we know about medicine, about health care, about end-of-life care, where does that come from? Friends and neighbors, absolutely, because we talk to people. The word-of-mouth referral in many situations is worth more than an official account. Someone who knows someone who works somewhere in healthcare. I have pulled these from my years of experience in geriatrics and in end-of-life care, and been confronted because something that I said was different than somebody, because, you know, my neighbor's daughter's cousin used to work at Beaumont, and she said that what you said wasn't right. Well, what did she do at Beaumont? Well, she worked in the laundry. But she knew that what I said wasn't right. So someone who knows someone, that's where we get some of our health information. The lady at the nail salon, or for the male equivalent of that is the guy at Home Depot. TV shows, movies, magazines, and books. This is more powerful. I opened you up with a couple of amusing examples, but this last one is very powerful. A lot of what people believe about health, about doctors, about medicine, healthcare, end of life comes from movies and TV shows and those types of Hollywood images about what disease does to people, how people cope with disease. Now, some of those are inspirational stories and they're worth looking at and thinking about. Some of it is absolute baloney, including the business about people who flatline on their heart monitor and somebody comes in and pumps on them a couple of times and they're, restored to health. But those images, we see them over and over again, and they form our notion in our heads of how things are supposed to go when we're sick, how our relationship with doctors and hospitals are supposed to be. And those Hollywood images are very powerful, but they can also be very destructive, and they can get in the way of good information and good conversation. The internet in recent years is the source of a lot of information. Some of it's even true. Now, when I was a kid in the 60s, I remember believing that they couldn't put something on TV if it wasn't true. And I think that some folks have that idea about the internet as well. They couldn't put that out on their website if it wasn't true, right? So the internet can be a terrific source of good information for people who know how to navigate the web and how to tell a reliable source from a bogus one. But let the buyer beware, because there's a lot of information on the internet that is not helpful. And even now, I am confronted regularly by family members, spouses, others involved in the care of a dying person who read something on the internet that was inconsistent with what I and my team were proposing for their care, and we had to work through whether what they saw was a reliable source and was a legitimate concern that should be dealt with, or whether they had kind of been pulled in on some nonsense and then had to sort that through for them. So all of these are sources where we get our health info. Lastly, and I put it last, from your doctor. Because what do we know about the doctor's visits these days? They're about 8 minutes long, if that, maybe 10. And what does the doctor do now when they come into the room? Half the time they have their head in the keyboard and they're doing their electronic medical record, right? The old days of Marcus Welby or Dr. Kildare, sitting down and holding our hand with a kindly touch and a conversation and assuring us and dealing with our fears, which probably never happened even in the old days. But that's what we think it was. And we've lost some of that. That ability to have a drawn-out conversation with our healthcare provider about the things we're worried about, the things we're concerned about, the options available to us, the treatments that are helpful, the treatments that are harmful. That's hard to do in 10 minutes, 8 minutes, 15 minutes. And it's hard to do in a hospital where it's noisy and people are rushing in and out, or even in a doctor's office where somebody's knocking on the door, let's go, there's another patient due. So our doctors, of course, are good sources of information on healthcare, but it's more difficult, perhaps, in the modern era to get that information from your doctor. And among the advantages and privileges that hospice and palliative care physicians have, because we do so much of our work in home visits and house calls, is that we have that time to sit with the family and the patient and talk about things, and there's nobody knocking on the door and nobody telling us we got to go 10 minutes, 15 minutes. That's a luxury of time that we have in our practice that many of the physicians don't have. So why is there so much mistrust? And I will assert my premise up front to this question, that there is a lot of mistrust when we're talking about end-of-life care, and that people listen to what somebody from hospice or somebody in the hospital or somebody from palliative care might say about a particular situation or a particular diagnosis, and they just don't believe it because it runs counter to all those sources of information that I've already shared with you and what people believe about what's going to happen next. We want to avoid the unpleasant realities. So the idea that this little lump that we just felt might actually be a cancer, just being human beings, we push that out of our minds and we reject that possibility. And even in the face of more compelling evidence, we just don't want to go there just yet. Or some other symptom of an illness that might be nothing, might be serious. How many of us put that off, don't investigate it? Finally, we become too sick or the symptoms are too prominent, we can't ignore it anymore. We just are hardwired as human beings to look for the positive, to reject the negative, and to avoid unpleasant realities. So we're up against that in end-of-life care because the whole business is unpleasant. And we realize that by the time a patient and family are referred to us, they've been receiving bad news at several stages along their journey. And it's just something that we have to deal with. We feel powerless and overwhelmed in an era when supposedly there are miracle cures available. Every day research comes up with a new treatment, a new drug for cancer, for heart disease, for lung disease. There are rock star doctors on every TV show. There are miracle pharmaceuticals and groundbreaking surgical techniques being developed all the time. And all of this is going on, but none of it is making its way to our situation, or so we think, because the news we got from our doctor may be unpleasant, or it may be something other than what we want to deal with. And the fact that we're just so close to having a cure for some types of cancers, or some type of neurologic disorder, or like an Alzheimer's, and it's there and it's almost in our grasp. is actually a very overwhelming feeling for a lot of people. And in spite of all of the medical technology that we enjoy, people feel powerless. How do I get access to that, to those miracles and those treatments that could restore me to health? We have that nostalgia for an imagined past. I made that reference to Dr. Kildare and to Marcus Welby. Things used to be better in the old days when it wasn't so technical and so internet and so complicated. It wasn't better in the old days. Women died in childbirth. Children died in infancy all the time. People with a cancer diagnosis, the doctors threw up their hands. There wasn't a whole lot to be done. Heart failure and kidney disease and liver disease, people succumbed to those. They died from pneumonia all the time, as we still do. So we sometimes feel that we have this nostalgia for an imagined past, and the fact that we're living in a current technological age, and that the healthcare system, for some reason, hasn't met all of our needs, triggers a little bit of mistrust and triggers that feeling that, boy, if we could just go back to an earlier time, we could get a handle on this, it wouldn't be quite so overwhelming. And then there's the phenomenon that I've already alluded to, which is called FOMO. Does anybody know what FOMO is? Anybody, your kids or grandkids haven't used that phrase for you? It comes from the social media world, and the young people talk about the fear of missing out. It's this anxiety that comes because you have the idea that everybody else is doing something fun or exciting, and you are not. You're not enjoying the great fruits of life that all of your friends and associates are enjoying. And in a medical context, the FOMO is what I hinted, that all of these treatments and all of these great surgeries and wonderful drugs and things are out there to cure all manner of diseases, but I'm not getting that. I'm missing out because I have cancer in my pancreas and the doctors have told me that there's nothing they can do for me. So where's my miracle cure? Where's my rock star doctor? So the fear of missing out on the cure and the medical miracle is something that causes a lot of people to reject end-of-life care, to reject hospice, to reject palliative medicine without really understanding what it is they're rejecting. All they know is they got bad medical news and they can't be cured, and it can be overwhelming to them. So I'm going to deal with 4 of these major myths, things that everybody knows, and try to convince you that there's another way of looking at each of them. The first is that hospice is a death sentence. Many, many times, now of course in face-to-face conversations with potential hospice patients and their families, people are too polite to ever say that. But we know they say it to each other, or they say it after we leave, and that they reject hospice because, oh, I know all about hospice. That's the death sentence. You go on hospice and a couple of days later you're dead. So we'll talk about that. Hospice means giving up. Older adults with advanced disease, really not a realistic opportunity to reverse it. And they'll say, well, I'm not ready to give up. Hospice means giving up. So we'll talk about that. Everybody knows that hospice means stopping the treatment. Particularly in the cancer and oncology world, but also with other illnesses, heart disease, lung disease. Everybody knows that when you come onto hospice, then they're going to stop all the treatments. And then they put you on morphine, and then a couple days later you're dead. Everybody knows this. This is among the reasons that people reject the opportunity. So we'll talk a little bit about that. And then lastly, everybody knows that hospice is a wonderful organization. But there's a twist on that statement that I'll mention as well. So the first one, hospice is a death sentence. Well, I don't want to spoil anyone's afternoon, but birth is a death sentence. Human beings are finite creatures. We have a lifespan. We maybe get our 70 years and 10. Some of us get less than that. Some of us get more. But the death of a human being is scripted at the moment of their birth. So if we're handing out death sentences, we should be careful about cause and effect relationships. Certainly, the reason that someone is referred to palliative care or hospice is not because they're doing real well. It's not because the treatments are working. It's not because the disease has been reversed and health is just around the corner. None of those situations is happening when someone has been talking to their physician or their provider and the recommendation to think about hospice comes up. So people die from their advanced disease whether they use hospice or not. There's nothing about coming on hospice that'll make something happen that wasn't going to happen anyway. It has been established now, and in fact it made a big splash about 2 summers ago in the New York Times. It was in the front page about a study that was published, and the people who used hospice when they were matched with another group of people that had the same diseases but chose to continue their medical care, the people in the hospice group lived longer. It sent shockwaves through the medical community, as you might imagine. What do you mean people who chose hospice lived longer? How could that possibly be true? Somebody knows the answer. Because the treatments that are often pursued for illnesses like advanced cancers are toxic. They harm people. The chemotherapy kills the cancer cells. It also kills the normal cells. That's why chemotherapy, in many cases, has side effects and makes people miserable. People who continue to take treatments beyond the point that they're doing any good are going to die faster than people who stop taking the poison and allow their system to reset itself a little bit. And so it wasn't a surprise to us who are in the industry that hospice patients live longer. And in addition, the hospice patients had all kind of support, all kind of help at home, all kind of caregiver support, and things that the regular care group didn't have. So of course they live longer. But everybody knows that hospice is a death sentence, and when you come on hospice, you die. Now, don't go home and say Paletta said that we shouldn't have cancer treatment because it'll kill you. That's not what he said. He just said that past a certain point in the illness, when the treatments are no longer effective, to continue to take toxic drugs and to turn away from symptom management often brings people to death quicker than if they accepted their situation and stopped the treatments. That's what he said. But it is now an accepted fact that in many circumstances, the proper application of palliative care and hospice can actually help people with a terminal or an advanced illness not only live longer, but live better, with better pain and symptom management and better support for their loved ones. So that's what we're really shooting for. Okay, how about hospice as giving up? Doctor, we know about hospice and it's wonderful, but we're not ready to give up. What is it that you're giving up exactly? Can you tell me more about that? What is it that you're giving up? Well, giving up hope. Giving up hope for what? Because there are realistic hopes, aren't there? And there are unrealistic hopes. I mean, that's true not just in end-of-life conversations, that's true across the board. So it helps us to think, what are we giving up? An opportunity for a cure? I think you can predict what I would have already said and would continue to say about that. Everybody that has a medical situation ought to seek the fullest, most complete treatment that they can get access to, of course. But at some point, in many people's illnesses, it's clear to everybody, including the treating physician, that the treatments aren't working anymore. And in fact, more treatment is leading to worse outcomes in a lot of people. Some of you may have witnessed or experienced this yourselves. So are we really giving up an opportunity for a cure? In a lot of cases, I would say no. We're giving up hope, but we're really not giving up an opportunity for a cure. That's already gone. So what is it that we're actually hoping for? Well, we'll talk a little bit more about that. I would submit to you that hospice is not giving up, it's just changing tactics. The doctors and the nurses and the other professionals that work in a palliative care and a hospice team, instead of saying we're going to eradicate the cancer from your body, they'll say let's switch gears and focus our energy on getting your pain under good control so that you can be comfortable, so that you're not nauseated so much, so that you can eat some meals with your family. Let's focus our attention, instead of trying to make your heart beat stronger, in at least giving you breathing easier so that you can have a conversation with your grandchild and so that you can sit up and be part of the family at a meal. Let's focus our attention on those kinds of things instead of some idea that if we do something that the cancer will disappear or whatever. So we just change our tactics and focus on comfort and control and symptom management, and that's what hospice and palliative care, medical and nursing care, is really all about. And as I said earlier, we try to get people on their own to realize that there are realistic and also unrealistic goals. And so this, I don't want to give up hope. You know, again, what are you hoping for? That the cancer disappears? Are you hoping that your heart is, for some reason, all of a sudden going to start beating again like it's supposed to? Or maybe that your lost memory and personality are going to somehow magically be restored? Is that what you are hoping for? There's nothing wrong with hoping for that. But that's not a medical plan of care that is going to improve anybody's life or help them face their situation with their family. Well, how about the idea that your pain and symptoms could be well controlled? That's worth hoping for, because a lot of people under active treatment do not have their pain or symptoms controlled. There's room for improvement in a lot of cases. How about hope that our loved ones can participate in care? That is an area where in the olden days it might actually have been better. Nostalgia for what did occur for generations when people became ill and didn't get better, and they took to bed, and the family gathered around them and helped them and took care of them until the end of their lives. We've lost a lot of that by embracing the technology, but also means dying in the hospital with tubes and wires coming in and out of everywhere, surrounded by strangers. A lot of people say, what I would really like is to go home, be in my own bed with my little dog at my feet, and have my family, help take care of me, if they're willing and able to do it. That's something worth hoping for. Hospice can make that happen. And how about sharing family legacies? Instead of being sick and isolated in an ICU room or in a hospital bed somewhere, how about the idea of being home with good symptom management so that we can go through the photo books and identify all these folks and tell the stories that have been in our family for generations, and maybe make a little tape or a video for our great-grandchildren to be, and do some of those family legacy closure activities that are so important to us at the end of life and that kind of depart the medical world and move into the spiritual. How about hope for that? How about get pain under control and get nausea and get some of these other symptoms managed so that we can go home and do that? That's something worth hoping for. So it's not that coming onto hospice or considering end-of-life care requires you to give up hope. It just encourages you to hope for realistic, achievable goals that will bring value to your family's life. Hospice means that all the treatment stops. I would submit that in hospice we actually provide some very aggressive treatments for people. There's some things that we do at the kitchen table or in somebody's bedroom at home that not that many years ago were only done in the hospital. And really all it needs is physicians and nurses and others who know how to do such things and aren't afraid to do them in another setting besides an operating or a hospital room. And so things like pain control, managing other symptoms, doing those things that allow people to stay at home, sometimes that could be very aggressive. IV medications, routinely done in hospice, including opioids, people who need strong pain medication to have their pain managed and fed in through an IV line. That's done at home now. You don't have to go to the hospital for that. and taking fluid off of the abdomen in people who have a horrible swelling, or doing other treatments like nutritional support, TPN. Those kinds of things in hospice patients are all done in a home setting. None of those is a reason why somebody could not be cared for at home with their family contributing. And so artificial feeding for people who can no longer eat normally. So these are examples of some very aggressive treatments in hospice and palliative care that are done in a home setting, and other things that are not on the list, like transfusions and other types of medications and treatments, are not necessarily denied to hospice patients, even though they may be modified to the situation. So I would hope to convince you that everybody knows that hospice means all the treatment stops is just not backed up by the facts. And then the last one, hospice is a wonderful organization. Hospice in Michigan is over 150 different organizations. And at cocktail parties, what I normally experience is people who believe that hospice is kind of like the post office. It's the same organization, but there's one, in every town and every region. And actually, hospice is 150 different providers in Michigan. And some of them are good, some of them are wonderful organizations, some of them are not. And they're all different from each other, and they all, in Michigan, they all compete with each other for patients. Many people in the community don't understand that part. There are mission-driven, nonprofit hospice programs, and there are for-profit hospice programs that are owned by large corporations that are headquartered elsewhere or here in Michigan, but the organizations can be very different, even though they both call themselves hospice providers. There are some providers for whom hospice is their core business. It's what they do. At Hospice of Michigan, I'm allowed to plug my own program at least once, end-of-life care and hospice care and advanced illness management is all we do. We don't run nursing homes, we don't run hospitals, we don't have doctor practices or primary care or do any other business other than managing end-of-life care for folks who need and want that service. But there are plenty of organizations in the city where the ownership has some nursing homes, they have adult foster care, they have assisted living, and they say, you know what, we could do hospice too, let's do hospice. Or they have private duty, home care. Well, we're doing home care for years, how about we do hospice too? It's an opportunity for them. It's a business opportunity. So there are many distinctions and many differences in hospice providers, and I think that consumers, which is potentially any of you, should do the research and ask questions about what kind of provider. In the same way you would research a doctor. Somebody needs a hip replacement, they're asking everybody they know. Who's a good orthopedic surgeon that does hips? Or considering a hospital or some other provider, people are comfortable with the idea of doing research into their healthcare needs, but then when it comes to hospice, they just kind of take whoever's close by or the first one that they hit in the yellow pages. I would encourage you to do your research. How many folks here know about the Jewish hospice in this area? And you know, of course, that there is no Jewish hospice. What you have heard of, what Rabbi Bunny Friedman's group does, it's a chaplaincy network. They provide spiritual care and support for patients and families at the end of life. But it's a chaplaincy. They don't do hospice care. There is no Jewish hospice in Detroit. I like to think Hospice of Michigan is the Jewish hospice because we work so closely with Rabbi Friedman and his group. And we refer people back and forth to each other and have many, many hundreds of cases together over the years. But, again, in casual conversation, I think we'll go with the Jewish hospice. When you do your homework, you'll find out that there isn't one. There are many options because the Jewish Chaplaincy Network works with many different hospice providers, including Hospice of Michigan. The question was, when someone comes on to hospice, do you keep your own physician or do you have to go and have the hospice doctor manage? And the answer is it's up to you. If you want to keep your own physician and your doctor believes that they have the expertise needed to continue the care, then you have that option. Many internal medicine or family practice or cardiologists, for that matter, physicians in the community do not feel that they have the expertise necessary to manage end-of-life symptoms, but some do. So it's the customer's choice to keep their doctor, or if they want the palliative care specialist to take over. And in an area like Detroit, I think many families do choose the hospice doctor in the same way that they want the specialist for their heart, they want a specialist for their muscles and joints, they want a specialist for their end-of-life care. But in Western Michigan and up north, more rural communities, the opposite is true. Most people want to keep their family doc, and then the hospice physician is just a consultant. So it's really what the person wants.
Because our time is limited today, and I suppose because you have the benefit or the burden of hearing from me at 2 more sessions, I want to leave time for Dr. Paletta to answer questions. As a consequence, I'm going to be very brief with the few legal myths or misconceptions that you'll see on the slides today. The first one says that decision-making capacity and legal competency are the same thing, and that if the patient lacks capacity or competency, such a condition is permanent. Let me tell you why that's not true, and there's a lot of confusion in this area. Decision-making capacity and competency certainly both have to do with the ability of a patient to make appropriate medical decisions for himself or herself. If a patient is deemed to be incompetent, that is a legal determination that is reached by a court. A court finding a patient being incompetent will appoint a guardian for that individual to make decisions. Decision-making capacity is not per se a legal standard or determination to be made. It is really one to be made by doctors and or psychologists or psychiatrists. Indeed, and we'll talk about this at the next session having to do with advanced directives with living wills and medical durable powers of attorney, when one appoints a patient advocate to act for oneself, that document is triggered when 2 doctors or a doctor and a psychiatrist or a psychologist determines that the patient lacks decision-making capacity. If that determination is made, then the patient advocate can make all medical decisions that are appropriate, and certainly those that are described in the advanced directive. One need not go to court to have a patient advocate appointed to act. As far as the permanency of capacity or competency is concerned, the fact is that patients' conditions fluctuate. Patients sometimes will be incompetent and other times could be competent, or depending upon the patient's illness or whether anesthesia is given or some other temporary condition has caused the patient to lack decision-making capacity, that is a condition that can change, as I said, can fluctuate over time. So the key is particularly for family members and doctors to talk to patients as often as possible, to find periods where the patient is lucid in order to determine exactly what it is that the patient wants to do. The benefit of an advanced directive, which again is a subject that will be covered next session, it's clear because that document permits us now to state what our wishes are in the future if we are unable to state them at that time. Forgoing life-sustaining treatment for patients who lack decision-making capacity requires clear and convincing evidence that this is the patient's actual desire. That is not a true statement. More appropriately, I guess I could say that it is partially true, but it is not always true. If you remember back to the first session that we had, for those of you who attended it, Foregoing life-sustaining treatment, particularly in Michigan, is governed by two court decisions, the Rosebush case and the Martin case. In Rosebush, the Michigan Court of Appeals determined that a patient who has never been competent, in that case a minor, but it could also be applied to an adult who has had some sort of disability for his or her lifetime and thus under the law was never deemed competent. For those patients, a withdrawal of life-sustaining decision or foregoing treatment is governed typically by a so-called best interest standard. What is best for the patient? What is the patient's prognosis? What is the invasiveness of the care being contemplated or provided? And whether that care is doing any good. The Martin case had to do, if you recall, with a patient who at one point was very competent, but as a result of an accident, a car-train accident where his car and everyone in his family were hit by a Conrail locomotive, Michael Martin was unable to make future medical decisions for himself. And the Michigan Supreme Court said, in that instance, if a patient once was competent, like all of us here, in order to forego life-sustaining treatment, it has to be shown that the patient, through clear and convincing evidence, wants treatment to be withdrawn or not provided at all under the specific circumstances presented. And that, I submit to you, is a compelling reason, as compelling a reason as I can think of, why all of us should have medical durable powers of attorney. Because we're all competent, we all have the ability to state our wishes now, and if we don't do so in the future, some court in this state might unfortunately decide that we never expressed our feelings, one way or the other. The third myth is that withholding or withdrawing artificial fluids and nutrition from a terminally ill or permanently unconscious patient is illegal and is a breach of medical ethics. Again, the proposition is not true. There are many court decisions, many statements from a variety of medical institutions and organizations indicating that the delivery of artificial food and water is deemed medical treatment, not extraordinary treatment, and whether or not it is continued can be and should be governed by appropriate medical decision, just as any other medical care is concerned. In addition, there are many decisions, not only of the courts, but throughout medical treatises and committees and organizations, that medical ethics are not breached when a doctor suggests that the artificial delivery of food and water is inappropriate or is illegal. Finally, the proposition that once artificial life support is started, it cannot be stopped without going to court. That too is a myth. If family members agree on a course of treatment and they are working with their physicians, and their physicians, and if the patient can speak, fine. If not, if the appropriate spokesperson within the family or under the medical durable power of attorney can speak, as long as there is an agreement on stopping treatment that is provided, that is fine. I remember some clients of mine years ago at Beaumont Hospital expressed that at that hospital, once artificial life support was begun, it couldn't be stopped. Well, that wasn't the position of the hospital at all. Indeed, if someone shows up at the emergency room and the hospital's job and the physician's job treating the patient is to stabilize the patient and then determine the patient's prognosis, you would want all measures to be undertaken, including, if necessary, the artificial delivery of life support measures. However, if the prognosis turns out to be such that regardless of the treatment provided, regardless of the artificial life support being provided, it will do no good, then it can be stopped. There's no question about that. Finally, advanced directives must comply with specific requirements and are not transferable between states. As I will describe at our next session, Michigan's statute is quite comprehensive. And I'll have the statute up on the slides, and I'll show you exactly what I have in my own medical durable power of attorney and what I use for my clients to satisfy the statute and go beyond the statute. But what about people who have their own documents? Will that suffice? Well, my position is that it is certainly better than nothing. I'd rather that your document comply with the statute, but if you have a document that you can't change because of your condition now, and the document expresses your feelings, even though it doesn't comply with Michigan statute, I submit that a court or a doctor or a hospital looking at that document will certainly give it weight. Because after all, the ultimate question to be addressed is, what are the patient's wishes? What does the patient want us to do in this particular circumstance? So even if there is an advanced directive that does not technically comply with Michigan's statutes, it is better than nothing. Can your document be taken to other states? Absolutely. Many states have provisions in their advanced directive statutes that render these sorts of documents portable so that you can take them from state to state. Michigan statute doesn't include such a provision. I don't know why that's the case, but it doesn't. But nevertheless, I have no doubt that if you have a properly crafted document that meets Michigan's requirements, it would be honored out of state. Dr. Paletta, he doesn't know that this is coming from me, but it is a question that someone asked at our last session, and I think that it ought to be answered. The question that was posed, and I'll repeat it here, is that Rabbi Miller or Rabbi Syme at our last session talked about the strong Jewish principle about a Jew should never die alone. And some people in the audience noted, some with guilt actually, that try as they did to be with their loved one until the patient died, it wasn't until they left the room that the patient actually died. Is that a medical based phenomenon? And how do you square that with the religious notion, the Jewish notion, that no Jew should die alone?
No, it's a blending, actually, of medical and metaphysical and spiritual phenomenon, and all of us have those things in our consciousness and in our minds, and we grow up thinking about them. I would tell you that it is a very common thing that families have set up a vigil around a dying person and are very fastidious about handing off to make sure that their loved one is never alone, and then that one moment that they're called to the phone or need to leave for just to go down and grab a cup of coffee, that's when the person chooses to die. And I say chooses advisedly. It happens so frequently that many of us who ponder the metaphysical are convinced that the dying person is waiting for their opportunity. They don't want to breathe their last in front of their spouse, their daughter, their close friend. And so when they have that opportunity to sneak it in, they do. And again, it happens too frequently to be haphazard. And so I'm a believer that many folks at the end of their lives are comforted by the presence of loved ones and will happily give up their ghost with people around the bed, and that there are other folks who do prefer to do that alone, and they will linger until such time that they can pass away on their own. And I don't know how you could find out in advance which one certain people are likely to be. The question is about the 6-month requirement for hospice care. And that has caused a lot of mischief, I must tell you, because the original intent of that 6-month rule was, remember, hospice became official as a benefit when Medicare adopted the program. Before that, there were hospice programs, but until the money came and Medicare gave the blessing, we weren't sure what hospice meant. Well, Medicare comes along and says, listen, we already have provisions for convalescent care, for home care, for nursing care, for long-term care. We want hospice to be separate and distinct from those. So they put this 6 months or less prognosis so that you wouldn't just have people on hospice for 5 years. It was intended to be a more intensive benefit for folks who were approaching the end of life. So what they said was, the doctor who certifies the patient as eligible for hospice says, I certify that if the illness runs its expected course, this person's life expectancy is 6 months or less. That's all the statement says. That makes a lot of doctors nervous. Many doctors still believe that if they certify someone for hospice and the patient lives longer than 6 months, that they're somehow guilty of fraud or at risk, which is nonsense. I would have been in prison years ago because I certified hundreds and hundreds of people all the time, and 40% of hospice patients live over 6 months. But the prognosis is the issue, not the eventual date of death. So when I look at a person who is failing medically, and I say, well, would I be surprised if this person died sometime in the next 6 months because of the illness and what's going on? No, I wouldn't be surprised. That meets the standard. If, on the other hand, I look at a person and say, I would be surprised if this person doesn't survive 6 months. Their problems seem to be fairly well controlled. They're functional, they're eating, they're moving around. I don't think they're going anywhere. Then that person does not meet the standard and should not be in hospice. So nothing bad happens if a person lives longer than 6 months. The hospice provider, in order to continue receiving payment from Medicare, needs to continue to show in their documents that the person just lived longer than we thought, but they still got all kinds of problems, and we still expect them to succumb to their illness. The question you're asking is, when is the right time to consider hospice? And regardless of the illness, whether it's a cancer, a heart disease, a neurologic syndrome, or whatever, the time to consider hospice is when a deliberative, proper medical and surgical approach to the illness has been followed and the person's not getting better. In fact, in many cases, they're getting worse. So I think it's a mistake for someone to say that they would be, just because they're a little bit older and frail and having some issues, that, oh, well, if I got sick, just put me on hospice. Well, there are a lot of illnesses that make you miserable but can be cured and you can enjoy a quality of life thereafter. Why would you choose hospice then? A better standard would be take all of the treatment that is available and take all of the opinions and options and weigh everything that's out there and undergo medical treatment for your condition. But despite that treatment, if you continue to get worse and it's becoming obvious to your doctors and to you that you're not improving and that this thing is not turning around, that's at least the time that hospice ought to be considered. That's when we change tactics, right? We don't give up hope necessarily, but we start hoping for more realistic things. I said, all right, my heart's not getting better. They've done everything they know how to do. So now I want to breathe better. I want to be more alert and awake. I want to be able to eat. I want to be able to play with my grandkids, shift my focus to realistic, doable goals. That's when. Someone is receiving hospice care at home and they have medical needs that are more than what perhaps a daughter or a spouse or someone could provide. Does hospice provide 24-hour nursing care?
Yeah, it's covered by insurance.
Well, all of hospice care is covered by insurance if people have Medicare, Medicaid, or some other type of insurance. If there are people who do not have any of those and are ineligible and have no money, the nonprofit programs will still take care of them. So no person should ever receive a bill for any service provided by hospice. That's one answer to your question. It is either covered or provided for you in terms of your insurance or the mission of the organization. But the issue about, and one of the misconceptions is the 24-hour care. The hospice benefit does not have a 24-hour care component to it.
So the family has to step in.
So either the family members can serve as caregivers, and if there are simple tasks like measuring medication or perhaps a simple wound dressing, the hospice team will teach family members to do those things, and many people are comfortable. Some people are kind of squeamish and don't want to do certain things. But the hospice nurse will visit the patient sometimes 2, 3, 4 times a week if that's what they need. But they can't stay 24/7. If a family can hire private caregivers, if they have the resources to do that, they'll do it. If not, then they really should consider receiving their hospice care in a nursing facility or a hospice home where the staff are there 24/7 and can provide it. How do you know who's a good one and who's not? And unfortunately, everybody has a slick brochure and a nice website and good literature. Ultimately, word-of-mouth referrals and the experiences of other people who have used that provider are probably the best. Well, I think you have to, how you find such people is asking around. And it's the same, you know, as I said earlier, it's the same. How do you find somebody to do your knee replacement? You find people that have had knee replacement and say, how was your experience? Did you like your doctor? Did they take care of it? Did insurance cover it? And with hospice care, it would be no different. Sometimes people are not told, as it sounds like you were not told, that you do have a number of choices. You have a choice of provider, you have a choice of location, where you want to receive your hospice care. You have the choice to keep your own doctor or use the hospice physician. And so some of it is just being a good consumer and knowing that you've got to do some homework and some research out there and find out what the market bears. The question was about Alzheimer's and similar type of dementing neurologic illnesses that from the time the person becomes disabled to the time that they die can sometimes be years. And so when is the right time for a patient with Alzheimer's or similar illness to come onto hospice? And as a rule, when the person is no longer able to walk, I mean safe ambulation is no longer possible. When they no longer control their bowel and bladder consistently, and when they really can't carry on a meaningful two-way conversation. Most Alzheimer patients reach that stage late in the disease. They can't walk, can't control their bowels, and really they might be verbalizing, but they really don't have good, meaningful two-way communication. That's when hospice can be considered for someone.